Very nice. It's now my pleasure to introduce Eric Dippel to the stage. Should OBLs have oversight accreditation, or should all CV procedures be done in the ASC? Hey, Eric, so what is the role of OEIS? It's good to see you, my friend.
Thank you very much, George, and thanks to Venki for the opportunity to be here. This is going to kind of continue on what Krishna said, OBLs. Just as a disclosure, I'm on the board of directors for OEIS. So I think it'd be worthwhile talking about what is an office-based lab and what is an ASC. I get asked this a lot: are OBLs going away? Are they staying? Are they going to get bigger, et cetera? But this is really some place that's been defined by CMS. CMS defines place of service where care is rendered. Any place that any kind of medical care is delivered, there is a place of service. For example, there's a place of service for a homeless shelter. There's a place of service for ground ambulance, for air ambulance. There's even a place of service for a parking lot in the case of a natural disaster. But in regards to an OBL, the place of service is the office. It's code number 11, as defined by CMS. An inpatient hospital setting is code number 21. An outpatient hospital is place of service 22, and an ambulatory surgery center is place of service 24. So when you're talking about these entities, we're really talking about a place of service. And if you're talking about our OBLs going away or ASCs going away or whatever, the place of service as defined by Medicare is not going to change. This is a definition that the government uses. What are some of the regulations that are associated with OBLs versus ASCs? OBLs are typically regulated by the medical board. Each state has their own requirements, and so what happens in my state may be different than what happens in your state. Many of these do not require certificate of need or special permits. There's no specific special regulations from Medicare to participate as long as the provider themselves is a Medicare participant. There are a few states, for example, Florida, Massachusetts, and I believe Illinois, that require inspections and accreditations, but again, that's state specific. ASCs, on the other hand, are a little more regulated. Again, they're also regulated by the state. They typically require a certificate of need or some kind of special state licensing, and there's usually strict layouts for building requirements. For example, the width of the hallway has to be a certain regulation. There has to be a certain number of beds, certain number of parking spaces. There has to be a separate bathroom for men and for women. There has to be a separate entrance and exit, et cetera. And this requires Medicare deemed status to receive reimbursement. So why has there been a proliferation of these outpatient settings over the past few decades? In 2008, CMS changed the reimbursement policy for outpatient intervention. In 2011, they bundled that with to cover atherectomy, and in 2020, they also expanded reimbursement for coronary PCI in the ASC. As Dr. Jane mentioned, there's approximately 750 OBLs in the country, and it's growing steadily. To me, really though, in my personal experience, why has there been a proliferation of the OBLs? Well, what are the similarities between a complex multi-billion cell organism like a human and a single cell organism like an amoeba? Is a primal desire to avoid noxious stimuli. And in my opinion, hospital administrators are a noxious stimuli. When you look over the past 50 years, there's been barely a doubling of the number of physicians in this country, but since 1990, there's been a 3,000% growth in the number of hospital administrators. In my opinion, they don't provide a whole lot to the hospital system, except making rules and regulations that really don't always pertain to patient care. And this has been a strong driving trend for a lot of people to leave the hospital system. Some of the benefits of the OBLs: patient satisfaction, they're orders of magnitude more efficient. The capital equipment is things that I wanted to purchase, that I felt like I needed for my equipment. It wasn't something I had to go to a VAC committee and had to speak to a dermatologist, a urologist, and a psychiatrist about. The personnel that I work with are hand-picked. We have one rule, that we have fun every day. We do clinical research. The OBLs are markedly more cost-effective than a hospital-based system, markedly less burdensome on the payer. Hospitals get paid approximately 40% more for the procedures that are done compared to what's paid in an outpatient setting. And over the course of years, we can save billions of dollars to the healthcare system. One of the things, for example, when COVID was at its peak, we remained open. I don't believe we were not regulated by the idiocracy of healthcare administrators. I had a nurse that had a daughter that had respiratory distress because her tonsils were so enlarged, but they wouldn't take her tonsils out in the hospital because that was an elective procedure. And I think that ASCs and OBLs put physicians back in the center of healthcare. That's what we went to medical school for. In hospitals, physicians have been kind of tossed to the side and are no different than the people that push the brooms down the hallway. Of course, there have to be safety. If there's not safety, I don't think these would go. And as Dr. Jane mentioned, this has been well publicized that these procedures can be done safely in a hospital, in an outpatient setting. And what is OES's role in all this? OES is a multidisciplinary organization. It's the only organization that's dedicated to the outpatient space. It was founded in 2013, and it really is based on the SCOPAC principles of safety, credentialing, outcome measures, compliance, appropriateness, and peer review. This is a quality standard statement that you can see on the website, but basically it's to promote the highest quality for our patients with safety and good outcomes in mind. It's based on 5 pillars of quality. There are commitments to safety, outcomes, clinical appropriateness, continuing education, and fiscal responsibility. There's an outpatient registry that we participate in. Right now we have 110 sites that are participating, 339 physicians. And this is updated as of earlier this week. To date, over the past, I think it's been about 7 years now, there's been 26,000 patients enrolled, 43,000 procedures, and so the data is quite robust, and I think that you can see that you can start to make outcomes that you can see from the different interventions that are performed. Each one of those graphs you can drill down on and click on, and it tells you more data. There's been a publication that's come out of this, and there's been quite a few more that are currently being in press. So what are the downsides of OBLs? I think that operators should not practice beyond their scope. If you're not capable of doing complex interventions in a hospital setting, you should not be doing them by yourself in an office. I think you need to be extremely meticulous to avoid complications. I think you need to be prepared for the unexpected. You have to have a well-defined plan in place for emergencies. We practice code situations with our team. We do not take shortcuts. We do not cut corners. I think CLIA is something I mentioned because I got a CLIA license to perform ACTs, which a lot of people don't. Reimbursement, I think that's something that gets criticized, but you have to be ethical in what you do, whether it's in a hospital or an outpatient setting. Accreditation is a whole other issue. There's a number of accrediting organizations, and I guess the question I'm going to finish with is, does accreditation guarantee better outcomes? I mean, if the width of your hallway is a certain width, or you have a certain number of parking lots dedicated to your space, is that going to guarantee better outcomes? Accreditation is very expensive. Who's going to pay for it? Do other societies provide accreditation services? Does ACC, SCI, SVS, SIR provide accreditation to their constituents? Do other specialties require accreditation? For example, dentists or oral surgeons. My daughter had her wisdom teeth pulled by an oral surgeon that practices above me. To my knowledge, they don't have no accreditation process, and I didn't question it. And the state-by-state requirements vary. So in conclusion, I think there's a strong growing trend for endovascular procedures to be done outside the hospital, and the place of service 11 and 24 are not going away. Procedures can be done safely in an OBL ASC environment, even complex interventions, CLI cases, but I think that operators should practice to their level of experience. Compared to a hospital system, patient satisfaction rates are significantly higher and healthcare costs are markedly lower. OEAS is a multi-specialty society that is committed to the highest standards, and we encourage all OBL and ASC owners to join OEIS to have their voice heard. Thank you for your attention.